I'm starting the session now. Good evening, everyone. I welcome you all to the ICRA teaching program. I request Dr. Sikandar sir to kindly begin the proceeding. Over to you, sir.
Good evening and welcome back everyone to session every Friday. So in continuation, two very important topics by esteemed faculties. First is ORADS by Dr. Rupa Ranganathan ma'am, and second is imaging of ovarian malignancies by Dr. Anuradha Chandramohan ma'am. I welcome both of you, and I welcome our today's moderator, Dr. Prema Subramaniam ma'am, who will be moderating this session. And our session begins with none other than our own coordinator, Dr. Rupa ma'am. So with this, I hand over session to Dr. Prema. Over to you, ma'am.
Thank you, sir. I'm sharing my screen. A pleasant evening, everyone. I welcome you all to the Women's Imaging session in ICRA Resident Teaching Program. Today, we have two important and exciting topics by eminent faculties. The first session is by Dr. Rupa Ranganathan on ORADS. The second session is on ovarian malignancies. The second session is on ovarian malignancies by Dr. Anuradha Chandramohan. Sorry, it's not opening now.
No problem, Prima. I'll take over. No problem.
I'll introduce Dr. Rupa Ranganathan. She's the lead consultant in breast and women's imaging at Kovai Medical Center and Hospitals. She's the lead for, she's the director of breast center at Kovai Medical Center and Hospitals. And her interests are breast and gynec imaging. And she's the coordinator for the women's imaging session in ICRA. Over to you, ma'am.
Thank you, Prema.
Thank you.
Is my screen visible and am I audible?
Yes, ma'am.
Yeah, thank you. Good evening, everyone. Today, I'll be talking on ORADS for the next 45 minutes. Let's see, why do we all need standardized reporting in the first place? It's because it gives us a consistent interpretation and it also decreases ambiguity, and it will help us to have increasing right radiological diagnosis. And not only we diagnose, but we also stratify the risk, which finally results in optimal patient management. So ultimately, by accurately characterizing the lesion, we have a better interdisciplinary communication, which finally results in correct patient management, so that for a benign ovarian lesion, we avoid an unnecessary extensive surgery or a biopsy. And for a malignant lesion, we would be able to help in optimizing the surgical outcome by proper referral to a gynae oncologist. So at the end of the talk, we will be going through the same set of cases, and we will see if we can get away with a term called complex lesion, which we all try to attempt to describe these 6 lesions, and we don't use the right terminologies. So when it comes to the reporting system, there are so many reporting systems that is available, but by and large, the commonly used reporting system, which is much more standardized now and it's more widely practiced, is the ORADS and the IOTA, which is the International Ovarian Tumor Analysis, which also has got an ADNEX model for risk stratification. So IOTA has got 3 important components, which are simple rules, easy descriptors, where you don't have to describe so much when you classically see a spotter-like lesion, where you can directly use these descriptors rather than describing so much about the morphological characters of the lesion. And finally, we also have an ADNEX model, which helps us to stratify the risk of that particular ovarian lesion of concern, whether it can be left alone as benign or whether it is an intermediate or it is frankly malignant. So the ACR ORADS also has got a similar group of, or the similar classification, which basically has got both an ultrasound and MRI, which has got a standard reporting lexicons, and which using those lexicons, we would be able to stratify the risk of the particular ovarian lesion of concern. So by and large, this is mainly for an average risk patients and not for a high risk lesion. And it is not for any acute symptoms like torsion. And it is also not for a non-ovarian, non-tubal origin, except for parovarian and a peritoneal inclusion cyst. And when you have a multiple ovarian lesions, we have to individually give the assessment, and the final management is driven by the highest ORAD score. And the description or the definition of pre and postmenopausal is a premenopausal is a woman who is regularly menstruating, and postmenopausal is a woman who has got a history of amenorrhea for more than 1 year. And whenever you assess ORADS using ultrasound, we always tend to use transabdominal and transvaginal whenever it is possible. And when transvaginal is not possible, we can attempt for a transrectal ultrasound. And when we deal with the ORADS from MRI, it is always with contrast imaging, and it is recommended to use a dynamic contrast imaging with the temporal resolution of 15 seconds, which we will see a little later. So the ultrasound ORADS has largely incorporated the IOTA lexicons and the ADNEX risk score, and basically the data sets from IOTA 1 to 3. And because IOTA is predominantly from the European group, so it has incorporated both the European and the North American approaches, and finally has given a concise recommendation. When you see the ADNEX model and the ORADS, it can appear that the ORADS has got a low specificity, but this is with a specific intention that we are dealing with an average risk women, and hence it has to be more sensitive than being specific. And as any other RADS that we had seen, it will definitely become better in future, and it is a process of continuous evolution, and we will have much the other versions which will be coming up later. When you see, why do we need an MR? Because when you do an ultrasound for an ovarian lesion, we have an approximately 20 to 25% of them as indeterminate lesions at the end of our ultrasound ORAD. And when you perform MRI, these indeterminate lesion drops down to close to 5 to 7%. And what is more important in ACR MR ORADS is it has a very good sensitivity and also specificity, about 90%. And when the ovarian lesion of concern has got no MR enhancement, the likelihood of malignancy is less than 0.01%, which is very important so that we avoid an unnecessary surgery and anxiety to the patient. So we will see both MR and the ultrasound ORADS side by side, because if you see, you don't have to learn ultrasound ORADS and then move on, because you can actually see majority of the lexicons are very similar in both the modalities. So it has major category, size, solid or solid appearing lesions, cystic lesions, vascularity, and general or extra ovarian findings, which is very similar to MR. The same has got a major category, size, shape, and contour of the solid tissue, signal intensity, lesion component, whether it is solid or cystic, enhancement, and general or extra ovarian findings. So if you look at it side by side, there is one major description on the MR ORADS, which is a signal intensity. And other than that, most of them are very similar. Ultrasound and the MRI, the lexicons are very similar. So we see how the major category is divided into physiological and lesion. So a lesion is defined as an ovarian or an adnexal pathology, which cannot be accounted as a physiological process. So that is called as lesion. So the physiological group of the findings that are seen in the ovary are follicle and the corpus luteum, and the lesion are divided as unilocular with solid component, multilocular with solid component, and solid lesion. So we have to get out of describing the ovarian lesion as complex lesion. And whether you see the ovarian lesion in ultrasound or MRI, we need to put fit in that particular lesion into any of these 5 major categories. So if you see examples, so this is a follicle, which is like a cyst, which is less than 3 centimeter. A corpus luteum is the one which is filled with internal echoes. It's basically a hemorrhage within the follicle after the ovulation with a ring of vascularity around it. A unilocular is basically a simple cyst which is measuring more than 3 centimeter, and a unilocular solid is a simple cystic lesion with no septation but has got an additional solid component which also may or may not show a vascularity. So when you have a complete septa which is running from one wall to the other, we call it, and dividing into multiple locules, we call it as multilocular cystic. So when you have a solid component within the multilocular lesion, we call it as multilocular solid. And solid is a one where it can be entirely solid like this, or when the solid component within the ovarian lesion occupies more than 80% of it. So you can still have a small amount of cystic portion, which is less than 20%, but the lesion is predominantly occupied by a solid component, which is more than 80% of the lesion, or it can be entirely solid. Both of them are called as solid. So the same definition applies for ultrasound and also for MR. So if you look at MR, it is the same. Instead of unilocular, multilocular, we tend to say whether it is a cystic lesion or it is a lesion with solid component or a solid lesion. So cystic lesion is divided into unilocular and multilocular. And then you can say unilocular with solid component, multilocular with solid component. And this solid component is further divided based on the enhancement. If you see enhancing solid component, you term it as solid tissue. And if you see a solid component which does not show any appreciable enhancement, it is called other solid component or a non-solid tissue. So that is why for MR, even for categorizing the lesion into major categories, we need a contrast. So always we interpret the ORADS MRI by giving a contrast injection. So only then we will be able to divide it as a solid tissue or an other solid component. So this is an example of a unilocular cystic lesion, multilocular cystic lesion, lesion with solid tissue. So this basically is unilocular with a solid tissue. Why I call it a solid tissue? Because with contrast, it is showing an enhancement. And so this is a lesion with other solid component. I see a intensely dark T2 area here, which is not a cyst, but on contrast, I did not see any enhancement. So this is a cystic lesion with a non-solid tissue or other solid component. And here, as I said, this lesion is not entirely solid. You have an area which is cystic, but this area, if you calculate, it occupies more than 80% of it, and hence you call it as a solid lesion. So you need to be clear about categorizing this lesion, because major categories also help us to put them in appropriate risk stratification. The second component that we look at is the size. The size, you need to give the maximum dimension of the lesion and maximum dimension of the solid component. Very simple. Moving on to the third aspect, which is a solid lesion. So in ultrasound, whenever you see a solid lesion, you will see the outer surface, which is the external contour, whether it is smooth or irregular. When you see a cystic lesion, you will see more of an inner wall is smooth or irregular. So if you see a solid lesion, you have to look at the outer surface or the external contour, which is smooth or irregular. And how is the internal content? Do we have an echogenicity, hyperechoic area here? Do we have a calcification or an acoustic shadowing? Based on this, the risk stratification changes. So the same thing in MR, we will see smooth or irregular, because whenever you see a solid lesion, you will see whether the outer contour is smooth as in this case, or whether it is irregular as in this case. So you will consider the contour and then we will see a little later. So if you are in an ultrasound, we will also look at the acoustic shadowing of the solid area. This is an acoustic shadowing from a papillary projection. This is an acoustic shadowing from the fat content within the dermoid. This is a calcification which is showing an acoustic shadowing. So whenever you have an acoustic shadowing, the probability of that lesion being malignant is less, because dermoids, cystadenofibroma, and a fibromas show acoustic shadowing. Even in an adnexed model, if you are using an adnexed model in your system, you can see that when you say acoustic shadowing is plus, the probability of benign increases. So the fourth component, which is unique to MRI, is the signal intensity. So what do we look at in signal intensity? The first is whether it is a homogeneous or a heterogeneous lesion. So the signal intensity is common for both solid and cystic areas. So you have to, when you see a solid lesion, you will look at all these parameters. And when you see a cystic lesion, again, you will look at all these parameters. So the first is the homogeneous signal of a cystic lesion, a homogeneous signal of a solid lesion. And this is an example of a heterogeneous cystic lesion. This is an example of a heterogeneous solid lesion. So you will see the homogeneity of the signal of either a solid or a cystic lesion. The second thing that we look at is the signal intensity. How is it in T2, T1, and diffusion? And we compare it with the iliopsoas for hypointensity on T2 and the CSF for hyperintensity. For T1, for a hyperintensity, we always compare a T1 hyperintensity with respect to the fat and the hypointensity with respect to the CSF. The same way, if you have a low diffusion, that means it is equivalent to a urine. If you have a high diffusion, it is more than that of a urine or in the bladder or in the CSF that you see in the spinal canal. So this is how you compare. And this is a hyperintense fluid. This is an intermediate signal. If you see the muscle, it is brighter than the muscle, but it is definitely darker than the fluid. If you can see, even the follicle has got a fluid and it is darker than the fluid. And this is hypointense. So if you see the muscles, you can see that it is as hypointense as the muscle. So that is how we compare. So the fluid is compared to the CSF, the hypointensity is compared to the muscle, and anything in between that becomes the intermediate signal on T2. On a T1, hyperintensity within this dermoid is compared to the fat. So on a T1, the hyperintensity is compared to the fat and the hypointensity is compared to the fluid within the CSF. Anything in between becomes an intermediate signal. So in diffusion, we have two B values, B0 and 800, wherein we see whether the diffusion restriction is present or absent. Here, if you see, the higher the diffusion, it is not brighter, so there is no diffusion restriction, as opposed to the second one, where you can see increasing hyperintensity or when you increase the diffusion weightage. So this is a diffusion restricted. So the high diffusion and the low diffusion. So we look at the homogeneity and we look at how is it in T1, T2, and diffusion when we describe an ovarian lesion on MRI. So the next common thing in ultrasound, and which also parallels for MR, is the cystic lesion. So whenever we see a cystic lesion, as I mentioned before, we look at the inner margin. Whenever we see a solid lesion, we look at the external contour or the outer margin. So inner margin is smooth or irregular, whether there are calcifications in the inner margin, and what is the content of the cyst, whether it is anechoic or hypoechoic. Do you have a low level of internal echoes? Do you have a fluid level? If you have a cyst, we also have to characterize them, whether it is unilocular or multilocular, and so we will look at the septations. So as I said, a complete septation is considered as a multilocular, and incomplete septation is considered as still as unilocular. And if you have any solid component, so unilocular and a multilocular cyst can also have a solid area. So whenever you have a solid component within the cyst, you need to look at the outer contour, whether it is smooth or irregular. So this is an example of smooth So whenever we see a cyst, we look at the inner wall and you can see there is an irregularity. So this is an irregular wall. There is a papillary projection with acoustic shadowing. That is called a papillary projection. You have a complete septation, so it becomes a multilocular cyst. This is a hydrosalpinx, so it just has an incomplete septation. And this is a low level, as this has got a anechoic fluid. This has got a fluid which has got a low level of internal echoes. So this is low level internal echoes. And we also have classical descriptors, as we see in the aorta, which wherein you can see there is a retracting clot here, there is a honeycomb appearance. You can directly call them as hemorrhagic cysts. You don't have to describe there is a unilocular cyst, there is some solid tissue like which is not taking up a vascularity. So we don't need to describe so much. Rather, this is a pattern recognition. There are standard characters of certain cysts, which we will go through one after the other, wherein by pattern recognition, you can directly name them as hemorrhagic cyst, and you can name these are the different forms of dermoid cyst. You can have a fluid, fat fluid level, you have an echogenic ball, you can have an acoustic shadowing, again a fat fluid level, and you can have some such appearances also with a calcification and acoustic shadowing. So you can have a pattern recognition of these cysts, and you can call them directly as dermoid cyst. And this is a typical low level of internal echoes and an hyperechoic nodule without any vascularity, which is adherent to the wall. You can directly call them as endometriotic cyst. So we have three pattern recognitions on ultrasound. One is the hemorrhagic cyst, dermoid cyst, and endometriotic cyst, where you don't have to describe so much. All these cysts are considered as unilocular. So even though you have so much of contents within, you will not use the term complex, or you will not use the term solid cystic. Rather, this is all considered as a group of unilocular cysts, and there are specific patterns. So identify those patterns, recognize them, and directly use the terminology for direct diagnosis. So the lesion components on MRI is cyst versus solid. We'll see. The first, we will see the cyst. So this is a simple fluid which is hyperintense on T1 and has T2 and hypointense on T1. So we will know that this is a simple fluid. So you can also have non-simple fluid. Again, like ultrasound, you can use these terminologies directly as descriptors. This is a mucinous fluid. This is an hemorrhagic fluid. Though you can have all these solid appearing, you know that there is no enhancement here. It is minimally hyper on T2. It is very bright on T1, not suppressed on the T1 fat sat, no enhancement on the subtracted image. So you know that these are just the hemorrhagic content with no solid area. So they are non-simple hemorrhagic fluid. So you have a non-simple endometriotic cyst. You have a T2 shading here, T1 bright on a fat sat image, no enhancement of solid, no enhancing solid tissue here. This is a non-simple endometriotic cyst. Again, this is bright on T1, suppressed on T1 fat sat, no significant enhancement on contrast. We know that this is a dermoid cyst. So you have a mucinous cyst, endometriotic cyst, dermoid cyst. You can give direct diagnosis of these non-simple cysts that you see on MRI. You have additional features of T2 shading here. You also have a blood fluid level. You have a fat fluid level. So all these fluid levels, T2 shading, are additional descriptors for to describe the findings. Now we move on to the solid component. So we saw the cyst. Whenever you see a cyst, you will look at the signal, and you will also look whether there are any direct descriptors of non-simple cyst. And then when you see an enhancing solid component, which we call it a solid tissue, there are 4 of them. So when you have an enhancing a solid tissue, which is like a nodule, you call it as nodule. When you have a branching or in the fibrovascular core and a particular architecture like a tree, you call it as a papillary projection. And when you have an enhancing irregular solid tissue along the septa, you call them as irregular septation. When you have large masses, you call it as large solid portions. So if you see enhancing solid component, which we call it a solid tissue, you will characterize them into 4 of these terminologies. And as I said, non-solid tissue or other solid components are solid-like appearance, but it is not showing any enhancement. And hence, even if you see all of them, they are definitely benign. So you see a hypoechoic nodule, you see a fat, you see hair, you see clots here, but none of them are showing an enhancement. So this is an example of non-solid tissue where you have fat, where you have hair, you have clots, you have debris. All these are other solid components. So we saw cyst, we saw enhancing solid tissue. We have also seen non-enhancing solid components or non-solid tissue. The next component that we look at is the vascularity, which is similar to MR, is the enhancement. First, look at the vascularity. So it is a subjective score, which is very similar to the one that is followed in IOTA, which is if you have no score, you give no vascularity, you give a score of 1. We have an intense vascularity, you give a score of 4. But what is very important here, you look at this case, you give a color score of 4. But what really happened? You can also give a color score of 2 here when you have a very high PRF. Maybe you give a color score of 3 when you reduce the PRF further, but still not the optimal range of PRF. So when you have a PRF of 0.3, that is when you have to actually assess the vascularity. So whenever you assess the vascularity of the solid component on ultrasound, make sure that your ultrasound settings are right before you give them a color score. So you have to make sure that the PRF is 0.3 to 0.4, and only then you will give the color score, because it's very important that a color score of 1 in a solid component is ORADS 3, which you call it as probably benign, and a color score of 4 comes under ORADS 5, which means it's highly suggestive of malignancy. So you can give a probably benign to a highly suggestive of malignancy by optimally setting the PRF. If you don't do this setting, your interpretation will be definitely wrong. So parallel to the vascularity, what we look at MRI is the enhancement. So we have a T1 FATSAT image with a spatial resolution of 3 millimeter. And more importantly, we need to maintain the temporal resolution of 15 seconds. And we have to attempt to make sure that we cover the lesion and also the adjacent uterus. If you do not have a dynamic MRI, what we can is possible is to have a relative enhancement at 30 to 40 seconds after the contrast injection, which will have a certain limitation, which I'll talk further, but we will attempt to give a dynamic contrast with a temporal resolution of 15 seconds. And with the, if it is not possible, we will still give a contrast to assess the relative enhancement at 30 to 40 seconds after the contrast injection. So what do we look at? We draw a 2 ROI, one at the myometrium and one in the enhancing solid component or the enhancing solid tissue. And we try to get the kinetic curve. A curve which will not have a shoulder and which will enhance very less than the myometrium is a low risk curve or a type 1 curve. The curve which has got a shoulder, but still the enhancement is way less than the myometrium is an intermediate risk or a type 2 curve. The curve which closely follows the myometrial enhancement, or sometimes even it's very minimally less, or it is closer to the myometrial enhancement, is a type 3 curve, which is a high risk curve. So based on the enhancement of the solid tissue, we characterize them based on the kinetics. So getting a good kinetic curve is crucial to characterize the solid tissue on MR for risk stratification. So this is a typical example of a type 1 curve. As you can see, this was an ovarian fibroma, and this was not having any shoulder like that of a myometrium. This is a typical type 1 kinetics. So if you see, there is a shoulder, but if you compare, the enhancement is way less than the enhancement of the myometrium. This is an intermediate risk or a type 2 curve. If you look at this, it reaches very close. It has the shoulder and it reaches close, and in sometimes it or even crosses the enhancement pattern of the myometrium. This is a high risk curve or a type 3 kinetic curve. So you will also have a question, how do I interpret when the uterus is removed? You still have a group of patients who develop an ovarian lesion after hysterectomy. The problem is we don't have a comparison with the myometrium, and hence type 2 and 3 can't be differentiated. You can draw a curve alone for the solid tissue, and you can see whether there is a shouldering is there or no shoulder. So type 1 versus 2 and 3 can be differentiated. So when you don't have a differentiation between type 2 and 3, you won't be able to differentiate ORADS 4 and 5, but still you can say that there is a chance for malignancy, or there is a no chance for or a very minimal chance for malignancy. So if you don't have a dynamic enhancement, as I said, you can have a relative enhancement of 30 to 40 seconds. What is the problem here? You will not be able to draw the curve at all. So you will not know whether there is a curve, because this curve is not possible. So there is no difference between the shoulder or a no shoulder here. So what is possible? These two versus this can be differentiated. So the problem here is 1 and 2 can't be differentiated, whether there is a shoulder or no shoulder, because both 1 and 2 enhances less than the myometrium, and because there is shoulder cannot be seen, you won't be able to differentiate 1 versus 2. And you can see the 3, which is actually close to the myometrium. So you basically can see whether myometrial enhancement is paralleling the ovarian lesion or not paralleling the ovarian lesion. And hence ORADS 3 and 4 cannot be differentiated when you don't have a dynamic. So that is a limitation that we have when we don't follow a dynamic assessment. So the last component of the lexicon is general and extra ovarian finding, which includes peritoneal inclusion cyst, parovarian cyst, fallopian tube descriptor, fluid descriptor, peritoneal thickening and nodules, and adenopathy. So hydrosalpinx, as I said, have a tubular cystic structure with incomplete septation. So we know that it is definitely hydrosalpinx. A peritoneal inclusion cyst is the one which takes the curve or the shape wherever it extends to. And a parovarian cyst, you can see the ovary separately and it is not having any ovarian tissue wrapping around, and you know that it is a parovarian cyst. A similar example on MRI, which is the hydrosalpinx here. There is a peritoneal inclusion cyst, and this is a parovarian cyst where the ovary is adjacent to it, and it's definitely not arising from the ovary. So we are very sure that these are parovarians. Again, these can be directly described as hydrosalpinx, peritoneal inclusion cyst, parovarian cyst, where they are definitely benign. So in a case of malignancy, we will see omental nodules, peritoneal nodules, adenopathy, and lot of fluid above the POD. And this is called ascites. So whenever we see a fluid, we will see whether it is restricted to the POD or it has gone above it. So this we call it as an ascites. So these are the additional findings that we look at. So the last component is risk stratification. So if we have to summarize this part, so basically we had seen the major categories, the classification doesn't change, the size doesn't change. Whenever you see the shape of a solid lesion, we look at the external contour. If it is a cystic lesion, again, on ultrasound, we look at the inner wall, what are the contents of the cyst. And when you see cyst here, we look at the signal intensity and whether it is homogeneous signal or heterogeneous signal, and the vascularity. Please remember the PRF has to be 0.3, and enhancement, you remember that dynamic contrast enhancement with the temporal resolution of 15 seconds, and the general and extra ovarian findings are same. So now you realize that it is not so difficult to learn simultaneously because both of them are very similar. If you understand how do we classify and what to look in a solid lesion, what to look at the cystic lesion, what are the parameters to assess the vascularity and enhancement, it is all pretty much the same. So the last the component that we are going to look at is the risk stratification, which is again very freely available, and I don't have to really go through every single example of what is an ORAD, ultrasound ORAD 1, 2, but I'll summarize you a little bit. ORADS 2, any unilocular. So when you see a lesion, a cystic lesion on ultrasound, the main thing that you look is unilocular or multilocular. So any unilocular cyst is either 2 or 3, which is benign or probably benign. So how do you differentiate 2 and 3? Is one thing which is you have to remember is the size. So any cyst which is less than 10 centimeter, which has either a classical benign descriptor or a unilocular simple cyst, which is less than 10 centimeter is 2, which is more than 10 centimeter is 3. And we finished the unilocular with that. And what comes in ORADS 3 in addition to these unilocular cysts, which is more than 10 centimeter, is a multilocular cyst, which is less than 10 centimeter, and a solid lesion or a solid appearing lesion with no vascularity. So if you see a multilocular cyst, which is less than 10 centimeter, you will give a straight ORADS 3. It is definitely not benign. It is probably benign. The chance of it being malignant is extremely less. If you see a solid lesion or a solid appearing lesion with a color score of 1, that means no vascularity, again, you're going to give them ORADS 3. What do we do with ORADS 3? We will ask for MRI as the next investigation. ORADS 4 and 5. So any cyst with a solid component is either 4 or 5. So a unilocular solid or a multilocular solid is straight 4 or 5. The chance of it being malignant is high, and we need further evaluation. And if you have a solid lesion with irregular outer surface, you frankly have ascites and peritoneal nodules, it all directly points to ORADS 5. So no solid lesion will be ORADS 2. No vascular lesion will be ORADS 3. And whenever you have a unilocular solid and a multilocular solid, you will be either 4 or 5. So remember, it's impossible to remember the whole chart, but by and large, you remember simple tips to remember to categorize them based on the findings. So what is the next recommendation we have to also remember in ORADS 2 is based on the size and based on whether the women is premenopausal or postmenopausal. Remember, well, postmenopausal women are the one who have got amenorrhea for more than 1 year. So if you have a less than 3 centimeter in a premenopausal or a postmenopausal, we don't follow them up. When it is more than 3 but less than 5, again in premenopausal, we do not follow them. And in a postmenopausal, you will follow them after 1 year. When it is more than 5 and less than 10 centimeter, sometimes it can be a functional cyst. So we follow them after 8 to 12 weeks. And if it's a postmenopausal lady, we will follow them only at the end of 1 year. A non-simple unilocular cyst, which by means is a hemorrhagic cyst, endometriotic cyst, or a dermoid cyst on ultrasound, when it is less than or equal to 3 centimeter, premenopausal lady, you're not going to follow her up. Postmenopausal, you will follow up at 1 year. But if any of the findings are concerning, you will ask for an MRI. Anything which is more than 3 and less than 10, again, you will ask for MRI. So this is for ORADS 2. Remember, anything more than 10, why we ask for an additional investigation? Because such a large cyst cannot be completely evaluated with ultrasound, and we need a cross-sectional imaging, because a small area of papillary projections or an irregularity can be easily missed on ultrasound, especially when the cyst is more than 10 centimeter. So anything more than 10 centimeter, we are not looking whether she's premenopausal or postmenopausal. We are going to ask for further investigation. And this is the recommendation for a ORADS 2 lesion, which by means all the cysts are less than 10 centimeter. So we also can summarize few risk stratification for MR, which means, again, any unilocular cyst with no enhancing wall or solid tissue is ORADS 2. A typical endometriotic dermoid cyst fallopian tube with simple fluid is ORADS 2. And what is more important in MR here is a solid tissue which is low on T2, low on diffusion. We will not look at the enhancement characteristics and we will downgrade them as ORADS 2. This is something very important. So a benign solid lesion on MR can be definitely downstage to ORAD 2, provided they have a very low signal intensity. What do you mean by very low signal intensity? The hypointensity is equal to that of the iliopsoas muscle. ORADS 3 is a unilocular cyst when it has a proteinaceous, hemorrhagic, or a mucinous content when the fallopian tube has non-simple fluid or thick walls, or a multilocular cyst comes as ORAD 3. So any multilocular cyst with no solid component is ORAD 3. That whether it is ultrasound or MR, you can remember that. And ORADS 5, it is straight ORAD 5 when you have these findings in addition to the ovarian lesion. If you have a peritoneal nodule or mental thickening, lot of ascites, you give them a ORAD 5. So how important is this kinetics? So when you see a lesion with solid tissue, which is not dark on T2 and diffusion, we categorize them as 3, 4, and 5 only based on the dynamic contrast enhancement. So when it has a low risk curve, it is 3. When it has an intermediate risk, it is 4. When it has a high risk curve, it is ORADS 5. So that is why the dynamic contrast enhancement becomes very crucial when you have a solid tissue in the ovary to categorize them as probably benign or highly suggestive of malignancy. So now we are going to come back to the same 6 set of cases, and we have the poll questions now. So we had seen 2 components of ORAD. One is the lexicon. So first step that you would do is we will try to categorize the lesion into 5 different types, and then we will look into the cystic component. What do we look at on ultrasound? What are the findings that you need to look on MRI? If you have a solid component, what will you see? Whether the contour is irregular, whether the vascularity with a good PRF, what is the color score? On MR, you will see what is the signal intensity, it is homogeneous or heterogeneous, and what is the kinetics. So based on that, we are going to try to either characterize the lesion or stratify this 6 set of cases. So we are not going to use complex lesion. Instead, we will try to assign the ORADs for these set of cases. Sarita, can we start the poll question?
Yes, ma'am. The poll is live, ma'am.
Yeah. So we have 2 different lesions, which I had shown you in my talk, and you will be assigning what ORADs that you would give for A and B. The first one is for A, and the second one is for B.
I'm ending the poll, ma'am.
Okay.
Ma'am, majority of them answered it as option 3, ma'am.
Oh, fantastic. So let's see. We know that this is a unilocular cyst. It has got a retracting clot with no vascularity. So we are going to use a simple benign descriptor, which is a hemorrhagic cyst. It's less than 10 centimeter, obviously. So this is an ultrasound ORADS 2. Again, this is a unilocular cyst. It has a hyperechoic content. It has got an acoustic shadowing, no vascularity. It is a dermoid cyst. It is a pattern recognition. We know that this is a dermoid cyst and it is less than 10 centimeter. So this is an ultrasound ORADS 2. Fantastic. So the answer is both of them are 2. The second one. So what is the ultrasound description for this?
I have started the poll, ma'am.
Okay. So look at the B mode ultrasound. Also look at all these to classify them as 1, 2, 3, or 4.
I'm ending the poll, ma'am.
Okay.
Ma'am, 100% of the attendees answered it as option 3.
Oh, fantastic. So you see this is a septation. So it is not a unilocular cyst. And you see, so you know that it is multilocular. And you have a solid component here. So it is multilocular solid. And I have given the a Doppler with so much of vascularity within. So this has a straight color score of 4. So it's a multilocular cyst, multilocular solid, hemorrhagic content, irregular inner wall, color score of 4. It becomes a straight ultrasound ORADS 5. So what do we do next? We need a staging CT and surgery for her. This was a case of serous cystadenocarcinoma. So what is this lesion type? How will you describe this lesion on either side
Poll
of
is live, ma'am.
Yeah.
I'm ending the poll, ma'am.
Okay.
Ma'am, majority of them answered it as option 4.
Okay, fantastic. So we know that this is a solid lesion. We are not talking whether it is enhancing or not enhancing. This is a T2 image, and the lesion is entirely solid. So whenever a solid component occupies more than 80%, we are going to call this a solid. So this is solid. And whenever we see a solid, we see the outer contour, the external contour. It is very irregular. So this is a solid lesion with irregular surface. So what is actually needed for this patient is a staging CT, and she had extensive peritoneal omental caking. So she underwent neoadjuvant chemo and a surgery, and this was a case of a high-grade serous carcinoma. Okay, so this is a little difficult case, but I would be happy if majority of you answer well right here. What is the ORAD? So this is the ultrasound ORAD will be A, and the MR ORAD will be B. So you have a lesion, and I also given a Doppler picture here to give you the color score. And we have a T1, T2, and we have a contrast.
I'm ending the poll, ma'am.
Okay.
Ma'am, we have two closest answers, option 2 and option 3.
Okay. See, this is a solid lesion or a solid appearing lesion on ultrasound with a color score of 1. We do not demonstrate any vascularity within the solid lesion. So it is a solid appearing lesion, color score of 1. And so we will give an ultrasound ORADS 3. You remember we gave all unilocular cysts which are more than 10 centimeter, a multilocular cyst, and the solid lesion with a color score of 1 come under ORADS 3. So we did an MR for her. In MR, you can see that this appears a homogeneously hyper on T2, homogeneously hypo on T1, and there is no vascularity. So what we thought, there is no enhancement here. So we downgraded this lesion as definitely benign, then this becomes an ORADS 2. So the right answer here is 3 and 2. On ultrasound, it is 3, but on MR, we downgraded it to an MR ORADS 2. Okay, the last case.
The poll is live now.
Okay, so the first ORADS assessment is for this. We have an ultrasound picture and we have also a Doppler. And then I have given you two sequences, the T2 and diffusion.
Ma'am, again, we have two closest answers, ma'am. Option 2, option 4.
Okay, option 2. Why do you think this becomes 3 here? So the only solid tissue which is dark on T2 and dark on diffusion, we will not worry about anything, the solid component, right? So that becomes a straight 2. If you have a tie-up between 3 and 4, I understand, but 2, you should not get confused. So this is a multilocular. You can see a complete septation. You have a solid area, which is a papillary projection here. It shows some minimal vascularity. So it is a color score of 2. It is a multilocular solid with a color score of 2. So it is suspicious. It's an ORADS 4. But if you look at MR, you see that this is the solid papillary projection that we saw, and it is paralleling the ileus signal intensity on T2, and I don't see any diffusion restriction here. So it becomes, I really don't worry about the enhancement I see on contrast, but because it is dark on T2 and dark on diffusion, it is an ORADS 2. This was a case of benign serous cystadenofibroma. So there are two things if you have to remember by downgrading. Though this is a solid appearing lesion, the previous one, it is not showing any enhancement. So when you don't see any enhancement, it is always benign on MRI. And if you see a solid component here and it is very dark, it is hypo intense on T2 and it is dark on diffusion, there is no diffusion restriction, you will not look at the enhancement characteristic, you will give them an ORADS 2. So ORADS 3, 4, and 5 on MR is the solid tissue, which means the solid component which is showing an enhancement, which is not dark on T2, not dark on diffusion. Only then we are going to look at the kinetics and give it as 3, 4, and 5 based on whether it is a type 1, 2, or 3 curve respectively. When you have this, you have to remember that is the power of MR, and that is how all the indeterminate lesions are rightly categorized, and we avoid an unnecessary surgery for a benign lesion. Okay, so answer is 4 and 2. So to summarize, we will get a good clinical history. We will understand that the women that we are imaging is an average risk with no acute symptoms. And we will also be sure that the organ of origin is ovary or indeterminate. And if it is an ovarian lesion, we will categorize the type of lesion, whether it's unilocular, multilocular, unilocular solid, multilocular solid, or a solid lesion. We will try to see whether they fit into any typical benign descriptors. And if you see a cystic component, you will look at the size, content, inner wall septation, solid component, and vascularity. When you see a solid lesion, you will see the size, outer wall signal, and again the vascularity or enhancement. And you will also look for associated findings as ascites, peritoneal nodules, or lymph nodes. And using all this, we will finally give the ORAD assessment with the risk stratification. So the only take-home point is stop using or describing an ovarian lesion as complex solid cystic lesion and try to incorporate either IOTA or the ORADS for a standardized terminology. Thank you.
Thank you, Rupa ma'am, for the elaborate presentation on ultrasound and MR ORADS with clear description of lexicon with lot of case examples. And thank you for summarizing the risk stratification system, which will be very helpful for our practice. And we have a few questions, ma'am.
Okay.
Can you explain T2 shading?
See, on a T2, you will have varying stages of blood products. Why? Because within an endometriotic cyst, every cycle it bleeds and rebleeds. So you have varying stages of hemorrhage within the cyst. And that is the reason that we have a T2 shading.
Thank you, ma'am. Role of thickness of septations in ORADS risk scoring.
In ultrasound, they mean?
They've not specified, ma'am.
Okay, thin and thick septations where we have a cutoff of 3 millimeter. Thin versus thick septation.
Thank you, ma'am.
Yeah.
Is there any size criteria to call as nodules and papillary projections?
No, it is only the morphology. It is not the size, and it should be at least more than 3 millimeter to call it as nodule. The size criteria to describe from an irregular surface versus a nodule, the nodule will be at least more than 3 millimeter, but a papilla versus nodule is basically the morphology. If the enhancing solid tissue has got a nodular morphology or a branching architecture, based on that, we differentiate as nodule versus papillary.
Thank you. And the next question is, when we have multilocular solid lesion with no vascularity, what is the ORADS category?
You can go back to the risk and see. It's so easy. You don't have to by heart which comes under what, but largely when you just scroll the images, you see, I'm seeing a solid lesion. So it cannot be a benign lesion. I'm seeing a unilocular solid and a multilocular solid. So it will not be 3 because we look at so many parameters. So it will come under 4 on ultrasound because only multilocular with no solid component is considered as 3. All others come under 4. But you really don't have to by heart so much. What you really have to have a good understanding is how to identify and describe and use the right lexicon. Once you are familiarized with the right lexicons, you have your chart on the side of your reporting table, and you can go through it, and that will help you to give. You don't have to by heart the ORADS risk stratification. All you need to be is to be aware of the small technical tips that we have to use, and the how to identify the descriptors and the lexicons. So this is a septation, this is a solid component, this is a multilocular, this is a unilocular. All that is the one that you need to be aware of. Don't try to by heart the risk stratification. You can always have the chart next to you and see it.
Thank you, ma'am. I hope after listening to your talk, the residents will be able to give the standardized lexicons and as well as give the risk stratification. It should be very useful for the referring doctors as well as the patients.
Thank you.
Thank you, ma'am. Our next session is by Dr. Anuradha Chandramohan from Christian Medical College, Vellore. Ma'am will be talking on imaging of ovarian malignancies. And
yeah, that's
Dr.
fine. Let's go ahead with the session. Yeah, I'm just sharing my screen.
Okay.
Yeah, sure. Thank you. After a very excellent talk by Dr. Rupa, let me now take you through the imaging of ovarian cancer. Very good evening, all of you. So in this presentation, I want to tell you why we should learn about ovarian malignancy, because it is not a very uncommon problem. It is ovarian cancer is the third most common gynecological cancer. In 2020 alone, nearly 44,000 women got diagnosis or received a diagnosis of ovarian cancer in our country. This is the one that is available in our registry, and you can kind of try to imagine how many more would be out of the registry. So every one of us who are practicing radiology, wherever we practice, we are likely to come across patients with ovarian malignancy. So it is good to have a good understanding of what is expected from a radiologist in a setting of ovarian cancer. So with that, let me just take you through some facts on ovarian cancer. So in 2014, when they revised the FIGO classification system, they put ovarian, fallopian tube, and the primary peritoneal malignancy staging system into the same box, and all three of them are now going to be staged in a similar fashion. So that's a good news for radiologists. So we don't have to break our head too much about trying to separate these different types of malignancy when it comes to for staging purposes. So having said that, the most common histological type of ovarian cancers are the epithelial ovarian cancers, which constitute more than 90% of cases. Among the epithelial ovarian cancer, the majority of them are high-grade serous ovarian cancers, which are 70 to 80%. A small proportion are low-grade serous ovarian cancers. The other types, like the mucinous endometrioid clear cell and the sex cord germ granulosa cell tumors, are all uncommon or less common ovarian cancer types. With this understanding, high-grade serous ovarian cancers occur in an older age group, in the postmenopausal age group, in the 50s and 60s. And majority of them present at stage 3 and above stages. So that is why most of the ovarian cancer patients who come to us will present in advanced stage ovarian cancer, because majority of them will be high-grade serous ovarian cancers. Rest of the histological types, the low-grade, the other types, and the stromal germ cell tumors, all present at an earlier stage. They have a relatively indolent course, and they are among the younger age group. So when you see a younger patient with ovarian malignancy, you need to think of histology that is other than high-grade serous ovarian cancer. This is an example of a high-grade ovarian cancer, which is platinum sensitive, but has a poor prognosis. And here you can see large irregular solid ovarian masses in the pelvis and extensive peritoneal disease, lots of ascites. So that's typically the case in a high-grade serous ovarian cancer. When it comes to a low-grade serous ovarian cancer, it is in a middle-aged women, and a proportion of these patients will have calcification. About 8 to 16% of them will have calcified pelvic masses. As seen in this example, there are calcified masses in the ovary, calcified peritoneal nodules along the liver as well. So these are less common type of ovarian cancer, but when we see these chunky calcifications within the ovarian masses, we need to alert the oncology team regarding a possible low-grade serous ovarian cancer, because these will not respond very well to chemotherapy. They have to consider surgery. The precursor lesion for a low-grade ovarian cancer is a serous borderline ovarian cancer, which appears as a multilocular cystic tumor with solid irregular papillary components within the mass. So this is a typical appearance of a serous borderline ovarian tumor in a very young patient. She was only 25-year-old. The irregular papillary architecture is said to be maintained even in a malignant low-grade serous ovarian cancer when these type of tumors turn malignant. Let's take a look at this example. This is a patient with ovarian cancer, which is seen as a unilocular cystic lesion with irregular papillary solid components. So this is a ORADS 5 lesion with associated endometrial thickening. So what are the type of ovarian tumors should we think of when we see a patient with endometrial thickening and an ovarian mass? We need to consider these histological possibilities: endometrioid cancer of the ovary, clear cell ovarian cancer, granulosa cell tumor, fibrothecoma, or a thecoma. So this is an example of a patient with endometrioid type of ovarian cancer, which is most commonly associated with endometriosis. And about 30% of these cancer type will have endometrial thickening. Out of those who have endometrial thickening, 15 to 20% will turn out to be endometrial cancer. The rest will be because of endometrial hyperplasia. And so whenever we're seeing endometrial thickening in a patient with ovarian mass, the endometrial thickening should also be biopsied and evaluated for a potential synchronous endometrial cancer. The other types of cancers that occur in a younger age group will be something like a stromal origin, or it would be a germ cell tumor like a dysgerminoma. These types of tumors can be unilateral, and a small proportion of patients with unilateral limited disease to one ovary may be amenable for a fertility preserving type of surgery. So now let's move on to seeing how do we image patients with ovarian cancer. When you pick up a malignant looking ovarian mass on your ultrasound, the next modality of choice is CT. CT has over 90% accuracy in staging. So how do we ensure that kind of accuracy? By having an optimal protocol. So what should be the protocol? It should be ideally a thorax, abdomen, pelvis. If there is no pleural effusion in the patient on clinical examination, it is all right to do an abdomen and pelvis, and to add on a thorax if there is pleural effusion, because the chance of pulmonary metastasis without pleural effusion is very minimal. Should we use oral contrast? Yes, we should use a positive oral contrast, and I'll show you examples, because positive oral contrast will help you in identifying the peritoneal disease better. We should use a split bolus technique to delineate the ureter. The section thickness for reviewing the images should be 2 mm sections, and you should review these images in both axial and coronal planes. So the value of positive contrast is in being able to differentiate serosal deficits from collapsed bowel loops. So that is the advantage of giving positive oral contrast. Also, giving positive oral contrast makes it easier to identify bowel luminal distortion and kinking, which are indirect findings which are seen in serosal deficits. So what is the role of imaging in ovarian cancer? The role of imaging is threefold. First, we need to say whether is it ovarian cancer. Second, we should be able to stage the disease. And third, we should be able to help with the decision time, meaning to say we should help the oncology team in deciding what should be the line of management. So how do we do that? The first question, is it ovarian cancer? In our country, every now and then, our MDT will always have an abdominal tuberculosis patient popping up in the list. How do we differentiate this abdominal tuberculosis, which has this diffuse peritoneal thickening, from ovarian cancer? If you look at the type of ovarian peritoneal thickening in this patient, it is very diffuse, involving both parietal and visceral peritoneum. It is extraordinarily smooth and uniform, and the amount of enhancement of this peritoneal lining is quite intense and uniform. And when ultrasound is done for these patients, it will be a multilocular ascites. So this is a pattern that we should keep in mind. And whenever we see this kind of peritoneal enhancement, we should think of an inflammatory infective pathology. Also, in our practice, it is not uncommon to see peritoneal hydatidosis, which can be as extensive as this example, where these lesions can have a cyst within a cyst appearance. Some of them can have calcification. And if we were to do ultrasound on these patients, there would be a trilaminar membrane if it is an active hydatid disease. And MRI might again show a daughter cyst within a cyst appearance because of the daughter cysts, and there can be a detached membrane. So these aren't minis, and keeping this in mind in our evaluation will help us give an accurate diagnosis. In every patient who come with bilateral ovarian masses, you should consider the possibility of Krukenberg's tumor. But the classic appearance of Krukenberg's tumor is the smoothly lobulated masses, or this kind of smoothly lobulated margins, as in the second example, which is called the bosselated margin, is typical appearance of Krukenberg's tumor. When we see solid appearing bilateral ovarian masses, 90% of them will be from stomach origin. So you must keep that in mind. And 80% of all Krukenberg's tumors are bilateral, and they are solid. And the most common primary from which they come is the stomach. So your review area while reviewing a CT scan of a patient with this kind of masses should always be reviewing the stomach for a possible primary. And I've shown you these two examples with stomach primary. Other primaries that you should consider when you're seeing solid Krukenberg's tumors are breast, lymphoma, and uterine malignancy. This is an example of bilateral cystic Krukenberg's tumor. 20% of them can be cystic, and 20% of them can be unilateral. When we see this kind of smoothly marginated ovarian masses, which are multilocular bilateral, you need to also consider, again, a Krukenberg's tumor. The primaries that you should be aware of that causes cystic Krukenberg's tumor is the colorectal primary, appendicular primary, or hepatobiliary primary. So gallbladder cancer, reviewing the pancreas and the biliary tree should be an important part of your checklist when you're seeing bilateral cystic Krukenberg's tumor, apart from reviewing the colon very carefully. Both these examples are from colonic primary with bilateral cystic ovarian masses. You shouldn't forget primary peritoneal carcinomatosis as a very close mimic of ovarian cancer. But in our practices, you should not directly only give primary peritoneal carcinomatosis as the only possibility. Always offer differential diagnosis of ovarian cancer or a primary peritoneal carcinomatosis, because the incidence of primary peritoneal carcinomatosis is way lower than primary ovarian cancer. And moreover, primary peritoneal carcinomatosis occurs a decade later than the usual high-grade serous ovarian carcinoma. So when you see older women with really small, normal-sized ovaries, but very bad, diffuse, disproportionate amount of peritoneal disease, as in this example with diffuse peritoneal thickening, normal-sized ovaries, mesenteric fold thickening, or mental caking, you should consider a possibility of primary peritoneal carcinomatosis, but give a differential diagnosis. Pseudomyxoma peteneae every now and then comes into the gynae-oncology MDT. However, the most common primary that causes pseudomyxoma peteneae is appendicular low-grade ovarian or low-grade appendicular mucinous neoplasm. So in this, whenever you see scalloping of the lower surface, a diffuse peritoneal process with low density masses, as in this case, a low density omental caking, you should consider possibility of an appendicular primary, and don't forget to review appendix in every patient with diffuse peritoneal process. This is an example of a typical mucocele of the appendix with bracket calcification, and a ruptured mucocele of the appendix would look like this. It is a low density, ill-defined diffuse mass within which is embedded a bracket calcification of a mucocele of the appendix. This is the example of a jelly within the belly. This is how it looks. This is how pseudomyxoma would look. Every now and then you might also come across multicystic mesothelioma. This is a rare diagnosis, but in our practices, when we see this appearance of numerous cystic masses filling the peritoneal cavity, think of bubbles in the belly. When you have bubbles in the belly, this is an Aunt Minnie, and the diagnosis is multicystic mesothelioma. This is a locally aggressive tumor which is amenable for cure, but the patient will be very miserable. So it's important to recognize this tumor and refer them to an appropriate center for treatment. Epithelioid mesothelioma will also mimic an ovarian cancer because it's a diffuse peritoneal process, but this plaque-like mesenteric fold thickening is the giveaway for the diagnosis. GIST, again, is a close mimic of malignant ovarian mass. Trying to connect it to the bowel is sometimes possible. Sometimes when it's in the pelvis, it is very difficult to differentiate this kind of mass from an ovarian mass. Usually the diagnosis is made with biopsy or with a surgery. So when the tumor markers are not fitting in, you need to also entertain a diagnosis of GIST as a possibility. And GIST is also a tumor that does not go to lymph nodes, but can have diffuse peritoneal disease and can metastasize to the liver. So what is our role in staging ovarian cancer? Staging ovarian cancer, our role is to do it accurately. A stage 1 cancer is when the tumor is confined to the ovaries, and a 1C ovarian cancer is when the ovarian tumor has ruptured and there is a spill of ovarian cancer cells into the pelvis below the pelvic brim. So that is a stage 1C cancer. What is our role in identifying this correctly and not biopsying? It is because a 1A cancer has got excellent disease-free survival of 98% at 5 years, but it drops to 75 to 80% if there is a rupture, if it is 1C. So we should not contribute to making a 1A tumor into a 1C. So there is no role for image-guided aspiration of a complex adnexal cyst without consenting with a gynae-oncologist. If it is potentially an early stage ovarian cancer, we should not attempt a image-guided aspiration of these adnexal masses. We must be careful. A stage 2 ovarian cancer is when the tumor is extended to the adjacent organs like the rectum, sigmoid colon till the pelvic, below the pelvic brim till the pelvic brim, or the distal ureters. So that's a stage 2B ovarian cancer. Stage 3A ovarian cancer is when there is a spread of tumor to the lymph nodes. It is again classified as 1 and 2 based on the size of the lymph node. And when there's microscopic peritoneal deficits, it's 1A2. But that is not something we will be able to see on imaging. Stage 3B is when the peritoneal spread above the level of pelvic brim is less than 2 centimeter. Stage 3C is when this disease is greater than 2 centimeter. Typically, an omental cake, when it is seen in a setting of ovarian cancer, it is a 3C ovarian cancer. Stage 4 ovarian cancer is when there is pleural effusion, it is a 4A, and it will become a 4A only when there is positive cytology. Ovarian cancer is 4B when there is metastasis to extraperitoneal organs, such as which also includes a lung, liver, spleen, inguinal lymph nodes, cardiophrenic lymph nodes, and lymph nodes outside the abdominal cavity. Again, a transmural bowel infiltration is also a 4B ovarian cancer. This is an example of an abdominal wall nodule. That's an example of 4B. Inguinal lymph nodes and axillary nodes, all these constitutes 4B ovarian cancer. So how do we help with the decision time? And how do we help with providing a report which can act as a roadmap to surgery is what is a third part of this presentation. So for that, we need to understand the management of ovarian cancer. The main management strategy for ovarian cancer is primary cytoreductive surgery. And this will be done only if complete removal of all visible disease within the peritoneal cavity is possible. If that is not possible, patients should undergo a neoadjuvant chemotherapy, downsize the amount of peritoneal disease, and then undergo interval cytoreductive surgery with or without HIPEG. HIPEG is hyperthermic intraperitoneal chemotherapy. So what is the importance of knowing what is the burden of peritoneal disease? The most important prognostic factor for both overall and disease-free survival is being able to achieve complete cytoreduction. So if there is complete cytoreduction, it will translate into good prognosis or better prognosis with definite survival benefit. But if there is incomplete cytoreduction, it will not result in any benefit. So the outcomes of an incomplete cytoreduction is equal to giving patient only chemotherapy. So, and these surgeries are very resource intensive, and also it has an inherent high morbidity and a mortality rate. And for this reason, we should be very careful in being able to convey and communicate what are the findings that will help the patient achieve complete cytoreduction, which findings when present will result in incomplete cytoreduction. What do we mean by complete cytoreduction? By complete cytoreduction, we mean that all visible tumor is removed. An optimal cytoreduction is when less than 1 centimeter of tumor is left behind in the peritoneal cavity. When more than 1 centimeter of tumor is left behind in the peritoneal cavity, at the end of surgery, it constitutes an R2 resection or an incomplete cytoreduction, which will not translate into survival benefit or disease-free survival or an overall survival benefit for the patient. So that is our role, and we need to be able to accurately estimate what is the tumor burden in the peritoneal cavity. The way of communicating effectively will be, one of the ways would be to use this acronym called POS. What does it stand for? P stands, this is an easy way of remembering what all should come into your report. P stands for the primary tumor and what is its local extent. PCI stands for the peritoneal cancer index. A is for ascites and abdominal wall involvement. U is for what are the unfavorable sites within the peritoneal cavity. S is for is there small bowel mesenteric disease, and E is for extraperitoneal disease. So let's go through these one by one. By P, I already alluded to you the importance of looking for another primary. Don't assume that the ovarian masses are primary ovarian cancers. It's a very important step in the way we review the exams, because just by probability, Krukenberg's tumors are way more common than primary ovarian cancer. So we need to always start reviewing the exam by looking for primary. And then you need to try to make up your mind to say whether it is high or low grade serous tumor. And then talk about what is the local extent of the tumor in terms of how is the plane with the rectum, sigmoid colon, and the ureter? Is the pelvic side wall musculature and the iliac vessels encased by the tumor? These have an important bearing in being able to achieve complete cytoreduction. So this is what should come under the P category. So this is an example of rectal infiltration by the tumor. It is important to report it because patient needs to be asked for consent for undergoing a colostomy in a patient. A patient who has this kind of finding should consent for colostomy, and it's an important step for the oncologist. And also it helps in getting multiple surgical teams together for operating this patient. And for example, a gynae oncologist might want to involve the colorectal surgeon to be able to operate within a short time or to be able to achieve complete cytoreduction adequately. So both these reasons, it is important to mention whether rectosigmoid colon is infiltrated or not. We use split bolus technique very routinely in our place, by which we mean that we are doing this technique to delineate the ureter and demonstrate what is the relationship of the tumor to the ureter. That is the aim of split bolus technique. So by split bolus technique, what do we mean? How do we do this split bolus technique? 40 ml of contrast will be given before the CT scan, approximately 10 minutes before the scan when the patient is still waiting for the scan to take place. And rest of the contrast, approximately 70 to 80 ml, will be given as usual through a pressure injector on the CT gantry. And then the study will be done in a venous phase. By doing that, we will be able to demonstrate the entire ureter, because ureter will be opacified by this contrast. And in this case, we can see how it is encased by the tumor. This is an important thing to report, because there might be need for ureteric implantation in this patient. And doing a study like this helps in planning the surgery better. Next, this is an example of pelvic side wall infiltration. Especially look at this left side. The iliac vessels are encased by more than 180 degrees. So that is definitely a very important finding to include in our report. Next, let's look at PCI. What is PCI? Peritoneal Cancer Index is basically a numerical value given to the disease in the different sites of the abdomen, and the sum of all these numbers will tell us what is the burden of peritoneal disease in the patient. So to start with, let's first understand what is the cutoff which will help in selecting a patient for primary cytoreduction. For primary cytoreduction, the cutoff is 20. But for interval cytoreduction, studies tell us that when the PCI is greater than 16, when the CA125 is greater than 550, when the age is greater than 60 years, it is associated with suboptimal cytoreduction, meaning to say the surgical exercise is going to be not useful in improving survival of the patient. Having said that, does PCI translate into predicting overall and disease-free survival? The literature on that aspect is very mixed, but there are one or two studies which tell us that the PCI cutoff of 13 and below have a superior overall survival compared to those above 13 among the interval cytoreduction group. Having said that, we need to understand that CT will underestimate the peritoneal cancer index, and CT will miss nodules that are less than 5 millimeter in size. So that is, it's very important to review the images with thin sections, that is 2 millimeter sections, to be able to pick up peritoneal disease adequately. So let's take a look at how PCI is done. To calculate the PCI, the abdomen is divided into 9 areas, 9 compartments, and the small bowel is divided into 4. So how do we divide it into 9? These vertical lines are through the midclavicular line, and the horizontal line, the top one is at the costal margin, and the bottom line is at the iliac crest. So this will divide the peritoneal cavity into right upper, epigastric, left upper, left lumbar, left lower, pelvic, right lower, right lumbar, and zone 0. So what is that we need to remember? We need to remember that greater omentum, though it spans from 3 through 0 to 7, it can only be scored under category 0. So even if the omental cake has got a longest dimension of 20 to 30 centimeters, it can get only a maximum score of 3 and it will belong to zone 0. So how is the small bowel compartments divided? It is divided by just dropping a vertical line through the umbilicus and a horizontal line through the umbilicus. And the small bowel loops in the left upper quadrant will be the proximal jejunum, lower quadrant will be the distal jejunum, the proximal ileum will be the right upper, and the right lower will be the distal ileum. So how is it scored? A score of 1 is given to a tumor that is less than 0.5 centimeter. A score of 2 is given for a lesion that is between 0.5 to 5 centimeter. And a score of 3 is given to a tumor that is greater than 5 centimeter. As you can see, radiologists are very good at measuring these, and so there is no need to take a caliper and accurately measure each and every nodule in the peritoneal cavity. You can eyeball and decide whether it belongs to one of these 3 categories, 0.5, 0.5 to 5, greater than 5, and you add up all the scores to get a PCI. So by doing this repeatedly, you'll be able to do this in a few minutes. Just 2 to 3 minutes will be enough to assess the PCI. Next category is the ascites. Among the mild, moderate, and severe ascites, it's a severe ascites, severe malignant ascites, by which we mean when the abdomen is over distended and every cut of the CT has fluid. Those kind of patients do very poorly. And this kind of large volume ascites is also associated with high-grade serous ovarian cancer. So it's important when we see large volume ascites, it should go as an important finding in the report. Second thing is to talk about abdominal wall involvement. As I already said, an umbilical nodule comes under 4B category, but a central small umbilical nodule can be excised easily. But this lateral abdominal wall nodule, when we attempt to excise this nodule, there will be compromise of vascularity to the abdominal wall, and the abdomen after the surgery cannot be closed. So that is why it is an important finding to mention when we are trying to plan the surgery, especially when there is such gross abdominal wall disease. Complete cytoreduction will not be possible. So these findings must come into our report and must be highlighted. Next is unfavorable findings. So we've classified the unfavorable findings as no unfavorable findings as U0. U1 is those that cause increased surgical complexity, and U2 are the ones when present, complete cytoreduction will not be possible. It is possible in a good number of patients where the PCI may not be that high, it might be less than 20, but a lot of unfavorable sites will be present, and so complete cytoreduction will not be possible. So these kind of patients we must recognize, and they must have neoadjuvant therapy to downsize the tumors that are present in unfavorable sites and reassess to see if complete cytoreduction is possible. That is the importance of noting all the unfavorable sites. What are U1 sites? Are the ones when present will increase surgical complexity. So these findings are very important for surgeons to plan the operation. So we need to mention whether lesser omentum, lesser sac around the fissures of the liver, is there a disease? We need to also mention if the stomach is encased, is the spleen involved, is there hydronephrosis, is there ureteric involvement, is there rectal infiltration, bladder infiltration, is it encasing external iliac vessels? These findings must be mentioned in our report to help with the surgical planning. What are U2 findings? And U2 findings are those findings when present. However expert the surgeon might be, they will not be able to achieve complete cytoreduction. So these findings, irrespective of surgical expertise, will result in incomplete cytoreduction and must go down as important findings in our report. For example, thick diaphragmatic plaque, lesser omental disease or fissural disease, which are more than 2 centimeters in size, disease in the lesser omentum causing biliary obstruction, multifocal small bowel serosal disease, route of mesentery disease, small bowel obstruction when it's present, pelvic sidewall infiltration, and nodes about the celiac trunk are important findings that must be highlighted in our report. Let's take a look at a few examples. So here in this patient, there is a lesser sac nodule. In this example, there is a nodule greater than 2 centimeter in the fissure for falciform ligament. There is also a lot of soft tissue density disease in the fissure for ligamentum teres. In this example, there is a large disease in the lesser omentum. Here there is a disease larger than 2 centimeter in the gallbladder fossa, and also notice the omental caking. And there is, in this example, there is a disease in the gastrosplenic ligament. If there is thick rind of soft tissue in the subphrenic space, this is very difficult to remove completely, because peritoneal stripping will be incomplete when we are trying to remove disease that is that thick. So these patients should undergo neoadjuvant chemotherapy. Small bowel disease, when it's present, must be highlighted because that is a complete no for cytoreductive surgery. There will be a lot of disease in the mesentery, cannot be removed, and this must be highlighted. For example, in this image, you can see that the small bowel is completely encased by soft tissue density masses. And here again, you have soft tissue density masses in the mesentery. So whenever the mesentery is kind of fanned like this, a closer look will show you that there are nodules. So when the mesentery is trying to show off like in this fashion, you should always suspect mesenteric disease. This example I already showed you. There is positive oral contrast and it's encased by soft tissue density serosal deficit. This is an example of tethered mesentery, where the bowel, which is supposed to float freely, is now tethered to the posterior abdominal wall. So this finding, when it's present, it's a very advanced disease. This is an example of transmural infiltration of the bowel by ovarian mass causing small bowel obstruction. If it is unifocal, surgery is still possible, but a multifocal serosal disease is a U2 finding and must be highlighted. So what we see on imaging is very advanced small bowel involvement and mesenteric involvement. What we cannot see is this kind of miliary nodules and plaque-like deficits. So this will be missed on imaging. So we must remember this fact whenever there is mesenteric and small bowel involvement by imaging. It is a very advanced finding and it must be taken very seriously. What are the extraperitoneal disease that we must highlight? We must say whether there is infiltrating serosal deficit or liver metastasis. Is there inguinal or cardiophrenic nodes? For cardiophrenic nodes, the cutoff is 7 millimeters. Are there lesser omental nodes, lung metastasis? This is an example of a deficit which is outside the liver. It is extrinsic to the liver. But whereas in this example, it is almost tucking into the liver parenchyma. That's an example of an infiltrating serosal deficit. How do we differentiate liver metastasis from the serosal deficit? Liver metastasis will make an acute angle of contact, whereas a serosal deficit will make an obtuse angle of contact with the liver parenchyma. Malignant effusion is a stage 4A disease. It is an extraperitoneal spread. It's a finding indicator of extraperitoneal spread. But whenever we see pleural effusion, we shouldn't assume that it is because of extraperitoneal spread. You need to prove it with cytology. And look at this example. There is enlarged cardiophrenic node. When a node like this is seen, it becomes a 4B. It's important to report these cardiophrenic nodes and not dismiss them, because in our own study, we've shown that even in a developing country like ours, all these nodes, when it's present, when the size cutoff is greater than 7 millimeters, it translated into lower recurrence-free survival and did indicate a stage 4B disease in primary ovarian cancer patients. So we must report these as an important finding. Inguinal lymph nodes and axillary nodes are again extraperitoneal disease which must be highlighted. So it is important to systematically review the images and try to give the components of POS, and we've shown it in our own retrospective study on patients who've undergone cytoreductive surgery for high-grade serous ovarian, epithelial ovarian cancer, stage 3 and above, that the POS score and the findings described in terms of POS does predict the outcomes of cytoreductive surgery. And so it is important to use this to communicate the findings effectively. So we've seen what is the role of imaging in ovarian cancer patients. We've seen the importance of staging it accurately, and we've also addressed the first question, is it ovarian cancer, in this presentation. So the take-home message is to pause and kind of communicate all the findings in a systematic manner. Everything that I said today is also given in this publication of ours, which you can review to learn more. And we've also in this paper given you a structured reporting template, which has all the findings along the line of POS, which you can use in your practice. These are some of the useful reads and references that you can look up to read more. And thank you very much.
Thank you, ma'am, for the excellent presentation. Whenever I report ovarian malignancies or peritoneal carcinomatosis, I will be referring to your article. It was great hearing from you directly on this topic, ma'am. And we have a few questions. How to differentiate pseudomyxoma versus cystic mesothelioma?
Okay. Okay. Both can cause scalloping of the liver surface, but cystic mesothelioma, you will be able to make a definitive diagnosis only with biopsy, but MRI imaging finding this kind of diffuse bubbly appearance cystic lesions that is filling the peritoneal cavity is very suggestive of cystic mesothelioma. Look at this. Within this, the entire peritoneal cavity has got all these cystic lesions, even the greater omentum. So that is very typical of multicystic mesothelioma.
Thank you, ma'am. Is there role for biopsy in a case that looks typical for ovarian carcinoma with omental caking and peritoneal metastasis?
Yes. In advanced ovarian cancer, which is not amenable for primary cytoreductive surgery, there is a role for ultrasound-guided biopsy to prove the histopathological type, to be able to administer appropriate chemotherapy, and it also helps in finding out whether it is associated with type of predisposing genetic factors like BRCA. And it also is helpful in identifying a small subset with low-grade serous ovarian cancer, where we know that the chemotherapy drugs will not respond well. So there is a role for biopsy. And also omental caking can be seen in other peritoneal, primary peritoneal malignancies like mesothelioma. So we need to there is a role for ultrasound-guided biopsy when primary cytoreduction is not possible.
Thank you, ma'am. If omentum is involved in left upper quadrant and not in central, will we score it as station 0?
Yes, wherever the omentum is involved, if it is thickened, the scoring will be only applicable to station 0.
Thank you, ma'am. If there is linear mesenteric thickening, is it still involvement?
A linear mesenteric thickening, any mesenteric thickening must be taken seriously, because mesenteric findings are not very well easily seen on imaging. But when radiologist, in spite of that difficulty, is going ahead and calling mesenteric disease, that must be taken very seriously by the oncology team.
Thank you, ma'am. There are no more questions.
Okay, thank you very much. Shall we close the session?
Yes, ma'am.
Okay, thank you very much.
I'm sharing tomorrow's flyer, ma'am. Is Rupa ma'am there, ma'am? Hello, Rupa ma'am.
I think you can go ahead sharing the
Yeah, yeah.
slide.
We're sharing Sundays, ma'am. We haven't received tomorrow's.
Okay.
This is the Sunday's flyer, ma'am. We haven't received tomorrow's flyer, ma'am. But tomorrow's speaker is Dr. N.L.N. Murthy, sir. Tomorrow's session is abdominal imaging. And this is Sunday's flyer. I'm closing the session now.
Oh, thank you.
On behalf of organizers, I thank everyone for being a part of this session. This is Sarita and Jahnavi signing off, wishing everyone a good night. With your permission, may I end the session, ma'am?
Yeah, good night. Thank you.
Thank you, ma'am. Good night, ma'am.